The final stage of the orthopedic evaluation is the detailed, hands-on assessment of appendicular joints in the axial skeleton. A mnemonic that is useful to remember is CREPIT, because we're assessing joints for crepitus, range of motion, effusion, pain, instability, and thickening. And then finally, we're assessing the axial skeleton for pain responses to manipulation. Starting with the manus. Most orthopedic disease is associated with the nails, the nail beds, and the pads. But it can also be associated with the interphalangeal joints and the metacarpals. The way I start is I take hold of an individual digit and I twist and pull and also flex and extend. And I go through doing this to each digit. If I get an adversive reaction, I'll come back later to see whether that was repeatable. And then I will start to look in detail at the nail bed, the pads, each interphalangeal joint to determine exactly where the problem is located, exactly where that adversive reaction was coming from. Particularly in Labradors, as you palpate these interphalangeal joints, you can pick up thickened joints indicative of osteoarthritis. Sit down. Good girl. Sit. Sit. There we are. As you're doing evaluation of the manus, don't forget to evaluate the sesamoids, and they're located just at the proximal end of the metacarpals. You can feel them here just above that large foot pad here. And particularly you want to pay attention to the sesamoids on the lateral and on the medial aspect. Don't forget to palpate the metacarpals here. What I tend to do is just run my thumb down those metacarpals, assessing them for any adverse reaction. The first thing we're going to assess with the carpus is whether or not there's any effusion or thickening. If you can feel the small bones of the carpus, if you can feel them fairly easily, then there's unlikely to be any significant thickening or effusion, both of which are associated with orthopedic disease of the carpus. The next thing I like to do is assess the standing angle of the carpus by looking at the distance between this pad and the ground. If this distance is decreased, that would suggest there's carpal hyperextension, which can be associated with trauma to the carpus, jumping down from a high surface. It can be associated with degenerative joint disease, particularly immune-mediated degenerative joint disease, or occasionally we'll see it as an idiopathic carpal hyperextension, particularly in German Shepherd puppies. Then, you sit down, sit down. Good girl. Then we put the carpus through a range of motion. Ordinarily, during carpal flexion, the pad should be able to touch the antebrachium, and carpal hyperextension is affected by grasping the distal limb, and we should be able to reach about 15 to 20 degrees of hyperextension there. Osteoarthritis is commonly seen in the carpus and is associated with a reduced flexion. So reduced flexion is very indicative of osteoarthritis of the carpus. At this stage, we're also going to assess the carpus for stability. We're going to test for lateral and medial stability. We're going to test for lateral stability by trying to force the carpus into varus, and medial stability by forcing the carpus into valgus. It's important to do this with the carpus in the extended position. If there's any flexion at all, you will be able to pick up what you might interpret as excessive valgus or varus movement. Also, while we're assessing the carpus, we take the opportunity to evaluate the long bones of the antebrachium, the radius and the ulna. Remember, in older dogs, osteosarcoma is commonly seen in the distal radius, and in young dogs, panosteitis can be detected as pain on palpation of these long bones. The first assessment of the elbow we made earlier on is really important, and that's one of the first things I repeat. Assessment of whether or not there is a dip between the lateral epicondyle and the olecranon. That dip there is normal, and if there isn't a dip, then that's highly indicative of effusion or thickening of the elbow joint, which could suggest orthopedic disease of the elbow. Now, the most common orthopedic disease of the elbow is elbow dysplasia, which occurs in young dogs. And that's a composite term covering fragmented coronoid process, osteochondrosis dissecans, and other developmental abnormalities. And elbow dysplasia leads to osteoarthritis. With osteoarthritis of the elbow, flexion will be reduced. Normally, the elbow should flex to this extent, where the antebrachium touches the brachium. With osteoarthritis, there'll be reduced flexion and often an adversive response associated with that. Now, the adversive response can be quite subtle. For example, usually when I perform flexion of an arthritic elbow, all I will detect is a pulling away of this area of the dog. It's almost, in equine terms, this is called the withers, and you just see the withers kind of rise up like that a little bit as you force flex the elbow. The same with elbow extension. As you put the elbow into extension, you may find the dog will just pull away from you, pull away from that manipulation slightly. Some people like to add supination and pronation during this manipulation. So flexion of the elbow with supination, internal rotation of the distal limb, and pronation, external rotation of the distal limb. They feel it's a more complete evaluation of the elbow. Now, in young dogs with elbow dysplasia, palpation on the medial aspect of the elbow joint, just over that medial coronoid process, can elicit an adversive reaction because that's where the pathology is. And to do that, I just place my thumb on the inside of the elbow joint there, just over the medial aspect of the ulna, and apply gentle pressure. At the same time as we're evaluating the elbow joint, we take the opportunity to palpate the long bones of the brachium, palpating the humerus. And just as we talked about with the antebrachium, panosteitis can be a common cause of lameness in young dogs, and osteosarcoma, in this case occurring in the proximal humerus, is not infrequently seen in older dogs. As you're palpating the humerus, remember that the radial nerve crosses the humerus at about this level here, and you can actually elicit a pain reaction, an adversive reaction, by pushing that radial nerve against the humerus. So that's just something to remember as you're palpating the humerus there. Okay, so the shoulder joint. Now, important diseases to bear in mind around the shoulder joint are in young dogs, panosteitis, osteoarthritis of the shoulder joint, biceps brachii tenosynovitis. And as we perform the shoulder manipulations, we always have to be open to the fact that there may in fact be intervertebral disc disease and nerve root signature signs coming from the neck. So let's go through the shoulder manipulations. Shoulder flexion is relatively straightforward. And while we perform flexion, I also like to perform internal and external rotation. And that can be particularly useful in young dogs with osteochondrosis dissecans lesions, making sure that the shoulder is comfortable through the full range of internal and external rotation. Next is shoulder extension. Now I want to show you what happens if you simply grasp the distal limb and try and extend the shoulder. The whole limb, I think you can see here, the whole limb moves forward. So to effect proper shoulder extension, what you need to do is to take two fingers on the front of the shoulder joint and push backwards as you move the distal limb forward. And you can see there we've got nice shoulder extension compared to what we had earlier on, which is simply the limb moving forward. The next test to do is shoulder flexion with concurrent elbow extension. Note I'm placing my thumb on the olecranon to effect elbow extension concurrently with shoulder flexion. And this stresses the biceps brachii tendon throughout its length, and particularly associated with concurrent direct palpation of the biceps brachii tendon is a nice test of the biceps brachii tendon. If you perform this manipulation, shoulder flexion with concurrent elbow extension and pressure in the bicipital groove, and you elicit an aversive reaction, that could be indicative of biceps brachii tenosynovitis. Some people talk about assessment of adduction and abduction of the shoulder joint, and certainly you can do that. If you're going to do that, you want to make sure the shoulder joint is in extension and then abduct the limb outward like that. And that's a test of the integrity of the medial stabilizing structures of the shoulder joint. Now, one thing to remember is that as you put the shoulder through the range of motion, you may elicit an aversive response that has nothing to do with the shoulder joint. Because as we perform flexion and extension of the shoulder joint, we're also pulling on nerves coming from the distal part of the neck. And if there's intervertebral disc disease, nerve root signature, we can often elicit an adversive reaction by simple shoulder manipulation. So always, if I get an adversive response to shoulder manipulation, I'll assess the neck for comfort. And I like to start doing that by simply gently palpating the muscles of the neck. And if when I do that, the ears start to be pulled back and often they'll shake like this, that to me is indicative of neck pain. Now you may have shoulder disease and neck disease, but it's important to evaluate both areas. Okay, so we finished the forelimb with an assessment of the scapula. And probably the first place to start with is an assessment of the muscle mass of the supraspinatus and the infraspinatus. Just as we talked about the fact that you'll see muscle atrophy of the triceps with elbow disease, muscle atrophy over the scapula is most often indicative of shoulder pathology, shoulder discomfort. As well as assessing the muscle mass, the supraspinatus and the infraspinatus, we can take the opportunity to assess the tendons of those two muscles as they run down onto the humerus there, just by direct palpation. We can also assess the stability of the scapula. It shouldn't move excessively dorsally, cranially, or caudally unless there is disruption of the supporting musculature. And if we haven't taken the opportunity to assess the neck and the axilla while we were doing the shoulder, then now's a great time to do that. Gentle palpation of the neck to ensure there's no neck pain, and then palpation of the axilla to ensure there's no pathology such as a nerve root tumor in the region of the axilla.